than of battle wounds. And it continues that all those military historians glorifying Greek generals oversimplify the ego-deflating truth. And the truth is that the winners of past wars were not always the armies with the best generals and weapons, but were often merely those bearing the nastiest germs to transmit to their enemies, not consciously. End of quotes. And the book is titled "Guns, Germs, and Steel: The Face of Human Societies." It was written by Jared Diamond. If you have a time, Google and read, you'll find quite a lot of historical perspective. I will address my presentation according to this outline, a very short context, then give the common denominators for epidemics historically, some key the definitions, just for the sake of our young colleagues. I will then look at some of the key factors that are facilitating pandemics and epidemics currently, and especially even in the past. Then I will zoom into the select some of the major epidemics and pandemics, first globally, and then take a few of them at the national level, and focus more later on at the end on the lessons moving forward. If you remember, for those of you in the association, exactly a year ago, in fact, I wanted to give this presentation. It was just at the beginning of the COVID. I think it was in February to 2020. And it wasn't possible. A few days later on, in March, we went into lockdown. And so it was not possible to do that. But basically, moving backwards, major public health diseases have plagued humanity from prehistoric and biblical era. In fact, I wrote an article last year looking at scripture for those who are interested, and looking at the disasters and the pandemics were epidemics in the Bible. And basically, unfortunately, there's nothing to suggest that these events will end soon. If anything at all, it looks as if things may be worsening. And globally, the obvious implication is that we are not adequately prepared for major upheavals. The COVID pandemic was the immediate cause for this lecture, but as I've said, I'll work you through out backwards to look at what has been happening in the past as an example. As at the 19th of February 2020, when I was preparing this initial presentation for COVID globally, there were only 90,000 cases and roughly about 3,100 deaths. And most of them were in China. In fact, outside China, there were only 166 deaths in 72 countries. A year exactly today, as I speak, as at 26th of February, we have 113 million cases of COVID and over 2.52 million deaths. I mean, just within 1 year. Just to give us a perspective of what can happen within a short period of time, in this particular case, a year. But as we move backwards, you'll be amazed at what has happened to our forefathers. And but before I move into the specific pandemics and epidemics, we just want to look at some of the common denominators for epidemics historically. Initially, there were interactions among man, environment, plants, animals, and microbes. And initially because man was just more of hunter-gatherers. There was very little contact with each other. And so the likelihood of people getting infected from each other was almost nil. Gradually, we moved into farming. Once we moved into farming, then there was domestication. When people started domesticating and grouping themselves into clans and other people, obviously the contact then increases. The likelihood of getting infected increase, and then people started passing on the microbes from each other and from animals. And the fact is that almost 10,000 BC to 8,000 BC, domestication of large animals like dogs, sheep, and pigs actually started. And so that basically then increased the likelihood of transmission of microbes from animals to man, from man to man, and that was what was happening. Interaction with germs are basically natural selection. To survive. Most of the interaction between microbes and why some of them increased in numbers. It's just a matter of survival of the fittest. And but gradually, the spread of germs was facilitated by opening the trade routes. And you see that from Columbus' time, when the conquest basically started, then you see what then followed historically. A few quick basic definitions. And the endemic is basically the usual prevalence of a disease or infection in a population. And then, but in an epidemic, simply put, is more than usual incidence or prevalence of the infection or the disease in the population over a specified period of time across a large region. That is basically epidemic. Jared Diamond, as I mentioned earlier on, categorized why infectious diseases become epidemics, and he was able to isolate three key things. He said that firstly, they are usually spread very quickly and efficiently, will result that whole populations get exposed within a very short time. That was one condition. Then secondly, was that they are acute illnesses. You either die or recover completely within a short time. That was in the past, and not before the introduction of most of these microbes. Then thirdly, he said that then those who recover usually, but not necessarily, develop immunity against recurrence of the disease for a long time. But what then happens is that the disease then dies off till either a new crop of susceptible develop through birth, or until an infectious person appears from outside to start the new epidemic. And that appears to be some of the historical pattern of what was perpetuating the epidemics in the past. Well, when we move to a pandemic, the definition of a pandemic differ depending on which agency you are using, but normally we go for WHO's definition. It says that an epidemic of an infectious disease that spread across a large region, usually a continent or worldwide, through human populations simultaneously, and usually it affects a wide number of people. The continents differ depending on the scale, but usually simultaneously a number of continents are affected at the same time, and the WHO's regions will definitely be more than 1, 2, 3, and thereabout. And he says that when 3 conditions, according to WHO, occur, then there's likelihood to be a pandemic. 1, there's an emergence of a disease which is new to a population, or let's say an infection which is new to a population. Then the agents infect humans, will start causing serious illness. And then the agents then spread easily and sustainably among humans. When the particular agent begins spreading and in a sustainable manner among humans, then the likelihood of a pandemic will is very high. Just as an example, using a flu phases, because they've categorized it into 6. I mean, usually depending for phase 1, at that stage, nothing appears to be happening. Only a few, especially if it's influenza. I'm using influenza as an example. It may occur in animals, but nothing specific is happening. You may not detect anything in humans yet in phase 2, but gradually the virus then starts posing a little risk to humans. You may get 1 or 2 people are affected. When you move to pandemic phase 3, then a human infection with a new subtype may occur, but there will not yet be a human-to-human spread. At that stage, once it has started moving from humans to humans, then it becomes potentially dangerous, and so they will put it at phase 3, depending on the scale. And when you move into phase 4, then small clusters of the human-to-human transmission across particularly one WHO region might have occurred. But the major problem then starts with phase 5, where there will be large clusters and then potential transmission across continents. And phase 6 then actually is the stage where there is increased and sustained transmission. And that one, the emphasis is on the sustained transmission in the general population. Then after some time, at that stage, WHO would have declared a pandemic earlier on, depending on the nature of the infection. And then we move back to the post-pandemic phase. There are contemporary factors now which appear to facilitate epidemics and pandemics. And one is the increasing globalization. And if you remember, as I said, once the trade routes started, then the increasing contact with the different people becomes a reality. Now, because of jet travels and other things, so within a matter of 24 hours, you can basically move around the globe. That definitely is a major threat. The second is increasing deforestation and exposure to new microbes. I mean, because people are moving into the forest. And as you do that, you get yourself exposed to new microbes that were not earlier on prevalent. And then it moves from animals to man, and then that happens. The third major point is the poor sanitary and veterinary practices that are happening. If you go to China and you see how they were dealing with the chicken poultry and the pigs and other things, then it's no wonder that that place is an incubator for the breeding of many microbes and others. There are other factors like overburdened health systems and then ineffective surveillance system. But one major concern is the global warming and the climate change that appears to be changing how microbes are growing up, breeding insects, snails, and other cold-blooded animals. In fact, there is on record that we are actually increasing the temperature of the globe 0.85 degrees centigrade over a number of years. And this appears to be increasing. And that is a recipe for the breeding of vector-borne diseases and a number of allergies and increasing air pollution that are favorable to the spread of pathogens and mosquitoes. And so that global warming and health, I think, may be one topic that one of these days we want a specialist to look at, because it has major consequences for us. Some of the consequences of epidemics and pandemics, because of the COVID, I'm sure they are very fresh. But usually people look at the mortality numbers, 2.5. But there's high morbidity. I mean, those who don't die actually suffer a lot, and there's distortion of the already fragile health systems. The very high social disruption. I mean, ban on funerals, ban on churches, ban on this, ban on that, and type of thing. I mean, so everybody is afraid of each other. And then if you are not careful, lockdown of whole cities. Apart from the health consequences, the economic implications are very, 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 very high. High costs for the individual, family, country, and international levels. I mean, you have to compensate people free water, free electricity, free water, and that. In fact, last year, within a month, there was 10% drop in the Jones market in the US, and then oil dropped by 30% in a day due to COVID. In fact, it nearly sparked the war between Saudi Arabia and Russia on 9th of March 2020. And the bailout plans in Europe and US is quite huge to that. Now, let's take a few of some of the key major pandemics that are occurred, and I will just select a few of them. The first one, during the 18th and Sparta War, between 430 and 405 BC, and quite, in fact, it said that a quarter of the Athenian troops were killed, and within a matter of 4 years, a quarter of the entire population that was affected were actually killed. It's thought to be the typhoid fever. So some of those causes may not necessarily be exact, but definitely, whatever be the case, there was quite a large number of deaths. We look at the Bubonic Plague, which people are thinking either smallpox or measles between 165 to 180 AD. And they were actually brought to the Italian peninsula by soldiers returning from the Near East. And it said that it killed a quarter of those who were infected, and a total of about 5 million people were killed by that plague. At that time, they called almost anything plague, not necessarily bubonic. But the real disaster that then happened from 541 to 750 AD, where bubonic plague was first recorded. And it started in Egypt. Some call it the plague of Justinian. And he said that at the height of it, 10,000 people were dying in a day in particular cities, and almost about 40% of the entire population were killed. I mean, if we take the population of Accra, and about 40% of the entire population being killed, then you can see that it wasn't a small thing. Overall, about 30 to 50 million people were said to have died, and that was quite bad. But as if it was not worse, the most disastrous epidemic was actually the Bubonic Plague that started in the 1346 and 1356. And Europe, it said that almost a quarter of Europe population actually died. And but by the time it went off, within Europe alone, over 20 million died in 6 years. but worldwide, the largest so far epidemic or a pandemic that had actually killed people is this bubonic plague of that year. And they said that about 200 million people actually died, not were affected. I'm talking of death. We so far we have 2.5 million deaths due to COVID. Columbia's voyage actually started from the 1492 to 1600. I mean, and they were trying to discover America, the Native America, Far East, and other things. And they said that the diseases that were introduced by Europeans killed almost 95% of the natives, far in advance of the Europeans, as the disease spread from tribe to tribe. And so it was actually the infections that wiped out the Native Americans than the guns and the ammunitions at that time. And that was quite devastating. It actually later on coincided with the introduction of smallpox, which killed about 56 million people around starting from 1520 AD, and by the year 1800, or almost 400,000 Europeans were killed annually. It's a historic fact that there's a small tribe in South Africa called San, and they were literally wiped off by smallpox that had been introduced by the Europeans, not as a biological warfare, but purely because of the adventure and attempt to colonize them. And so that really was disastrous. Cholera has been a major epidemic, pandemic in the past, and there have been 8 pandemics of cholera. The first starting 1816 to 1826 from the Indian subcontinent, and before receding to China. Second pandemic, 1829 to 1851, that reached Europe, Canada, Ontario, USA. But the third pandemic was really the one that killed quite a lot of people, especially in Russia. And it said that almost about 1 million people died around 1852 to 1860. But the fourth pandemic to the 8th pandemic rolled from 1863 to 1875, and that one is said to have started from Indonesia. And that is basically what is currently ongoing, which has metamorphosed to the Elto strain in 1962 to 1966. And so cholera, even though now appears to have died down a little, has been with us for quite a long time. Then the influenzas reared their ugly head. And I'm sure the classical one is the Spanish flu, which was an H1N1 in the 1918, soon after the end of the First World War. And it said that it killed actually 40 to 50 million people globally. 40 to 50 million globally, just around 1918, thereabouts. And it occurred in 3 waves. Very interesting, over a period of 2 years, from mild to moderate to severe. And before it ended, about 500 million people had been affected. And as I said, almost 50 million of them had died. And so it was quite devastating at that time. And I'm sure it was because probably that was the first time the influenza virus was spreading across. The second influenza pandemic was an H2N2, that was 1952. 2 million people died, the Asian one. And then the Hong Kong influenza, 1968, 1 million people dying, which means COVID has basically exceeded the Asian and the Hong Kong one. There have been some, I'll call them minor epidemics, pandemics, affecting mostly the birds and the animals. The familiar one, if you remember, it was the avian or bird flu, which in 2003 was actually a major issue, even though it started around 1997. Fortunately, there was only about 861 cases of human infection with 455 deaths from 16 countries before it basically died off as at that time. And there was quite a lot of the disaster among the poultry. And the waterfalls, which are familiar even in Ghana, are thought to be transmitters. And there are major flyways of migratory birds that usually perpetuate that. Ghana appears to be on this one, the blue one, the Black Sea Mediterranean one is where they breed, and they roost in a number of areas in Ghana that are well known, and so they all serve as potential sources of H1N1 infection. No, the H5N1 infection, so swine flu, bird flu. Then the swine flu came in 2009. That was mostly among pigs and the like. I mean, it started from Mexico, USA. Overall, about 16,000 people died. And by the 10th of August 2010, the WHO had declared it over officially. We are hoping that sooner than later, COVID will also be declared the same way. Just a few things to mention about yellow fever, just to let you know that it's not only in Africa or in Ghana that we have yellow fever. In fact, it actually was a major problem in the Caribbean and in America in the 18th and 19th centuries. And it's said that almost about 5,000 out of a population of 45,000 died. And so the mortality at that time was quite high, and it affected quite a number of big cities in Philadelphia. Fortunately for them, that appears to have been wiped off. But it's still very endemic in Africa. And in 2013 alone, about 78,000 people died from yellow fever in Africa. No, not in the world, in Africa alone, despite the fact that as far back as 2005, the yellow fever initiative was launched, and there is an effective vaccine, to combat it. And so the fact that there is a vaccine does not necessarily mean that you wipe off a particular pandemic, depending on the nature of the disease and the behavior of people. Ebola virus disease is basically endemic in Africa, especially in the DRC and Uganda, Sudan, and Gabon. But unfortunately for us, between 2013, December 2013 to 2015, it spread to West Africa, Guinea, Liberia, Nigeria, Senegal, Sierra Leone, and at least over 11,000 people died. And with a case fatality of almost 25% to 90%. And so Ebola is actually very dangerous. And if there's a combination of Ebola and COVID, then we are really in trouble, because the fatality rate is higher, and even though COVID's infectivity appears to be higher than Ebola. that basically, unfortunately, in March 2020, there was a recurrence in the DRC, and even though it affected only 3,444 cases, almost 2,264 of them died, and then so you can see that the fatality is quite high in that. Recently, as you know, we've had a few cases in Guinea, and there are still some recurrence in DRC. Lassa fever, just to mention that, is also hanging around our neck, also quite infectious. It has been isolated, and now it's almost endemic in Benin. Ghana actually recorded Lassa fever in 2011. Guinea, Liberia, Mali, Sierra Leone, Togo. And so along the West African countries, Lassa fever is also still around. The case fatality rate is not that high, about 1%, but depending on management, it can be as high as 15%. Measles, even though we appear to have forgotten about it, was causing a lot of havoc in the past. I'm not talking of Ghana. I haven't come to Ghana yet, but in Central African Republic and even in the US, measles was quite a problem, and until recently, that was a major challenge. Now that the vaccination theories and other things came, and there was a decline in the vaccination coverage, there was a rebound of measles cases in a number of European and North American countries. It's a lesson to us. I'm just chipping in HIV/AIDS because we appear to have forgotten about that, but it's on record that since 1981, about between 25 to 35 million people have died of HIV/AIDS. That's the only thing I'll say about that. And then the coronaviruses, familiar one, SARS, CoV, 2002 to 2003. That was what happened with a fatality rate of about 10%, and starting once again from China. A familiar one, which is called the Porcine Epidemic Diarrhea coronavirus, that affected more piglets, but not humans, but it basically wiped out almost all the piglets in the US, with 10% of the US population, piglet population, dying. Then the MERS-CoV, which in 2012 also started a few cases in the Middle East with a case fatality of over 36%. Starting in Saudi Arabia, the Arabian Peninsula, basically almost all the countries there have been affected. And though it appears to have died down, it's still a potential threat and it's still hanging around. I've already indicated the COVID mortality as at now, over 2.52 million deaths, compared to the previous ones, 30 million, 50 million, 200 million, and the like. And as you said, it comes in waves. And so if wave one goes off, it doesn't mean that we are okay. Wave two may come. At that time, they did not have the luxury of having a vaccine. But well, let's see what the vaccine will do to us. A few examples of what has been happening in Ghana. One is that Ghana was affected by the bird flu and the swine flu, 2007, thereabout. Fortunately for us, there were no human cases detected, but a number of our birds were affected and they had to be declared. Ghana experienced its first wave of cholera basically around 1980, peaking in 1983 with over 15,000 cases. I'm sure before then there might have been some isolated cases here and there. But another wave occurred in 1991 with almost 14,000 cases. And since then, the disease has been endemic in the country. Initially over a 10-year period, diminishing to 5-year period, and then now it has become almost endemic. Fortunately for us, I don't know whether because of the increasing washing of hands or whatever, for the past 2 years or so, at least we haven't had an outbreak. But the last major outbreak recorded about 28,000 cases with 218 deaths. That was in 2014. And this graph shows the periodicity at that time. The major initial one was 1983, 15,000 cases, 1991, 13,000, then a drop to 1915, then 1999, and thereabouts. The last one, as I said, in 2014 was over almost 29,000 cases. Now we have only a few cases every year. CSM is endemic in Ghana. Fortunately for us, because of the vaccinations and others, we appear to be a little on top of it, apart from the fact that different strains keep on emerging. But in 1997, that was the major epidemic, where about 19,000 people were affected, and I think over 1,000 people died. And that was where the spike actually occurred. Fortunately for us, even though every year we have cases, they are not as strong as in the past. Yellow fever is still endemic in Ghana. Fortunately, because of the vaccination program, there's occasional outbreaks, especially in Bubusa, Katsina Nankana, the districts, and Kintampo South in Brunafo region. Those are the endemic areas, and because of vaccinations, only a few cases are usually now reported. Measles was a tormentor, and I remember I keep on saying that it was measles that changed me to become a public health physician when I was a young listener. Because when we were seeing how people were dying, I mean, in 1980, I mean, you go to the ward in Companoche, and the wailing of the mothers that will you face before you enter the ward every morning, every single morning, not less than 5 days. I mean, of all types. I mean, I was wondering whether that is the only thing I can do. Can't I do something? Well, I mean, to stop that. That was the beginning of the mass campaigns with polio, measles, and other things. And you can see that now it's almost nil. Most of the cases are actually even German measles, and that is quite good. Now, to end, I will move then to lessons for dealing with contagious diseases. And I will just quote one scripture passage, not because I'm preaching, but because of the public health importance of that. It's from Leviticus 12, 1-3. It's an interesting quote. It says, the Lord said to Moses and Aaron, if someone has a swelling, an eruption, or a shining spot on his skin, which could develop into leprosy or a major skin disease, he might be brought to Aaron. The priest shall examine the sore, and if the hair on the sore has turned white, and the sore appears deeper than the surrounding skin, then it's indeed a sore of leprosy. When the priest sees this, he shall declare the person unclean. I mean, you see differential diagnosis at that time a form of contact tracing, case definition of various conditions, even at that time. And the last quotation is also from Leviticus 13, and it's also because of its health interests. He says a person infected with leprosy must cover his upper lip, and cry, unclean, unclean. As long as the disease lasts, he shall be unclean. Therefore, he must live away from people. He must live outside the camp. Use of face masks, isolation, quarantine, social distancing, risk communication, unclean, unclean. Cover the upper lip. He must live outside the camp. All these are even from biblical times. And the principles are basically the same as what we are using. What are the major lessons that we can learn from all this? First, recurrent threat of new and re-emerging epidemics and diseases of pandemic potential are going to be with us with increasing consequences. Well, whether we like it or not. I mean, it is, somebody called it the new normal, but there's nothing normal about this. But it's a new reality. I mean, whether we like it or not, that is what is going to happen because our habits are perpetuating that. There may be unintended consequences of biological warfare and research that can go berserk. I mean, not at times, not intentionally. Just as the armies in the past introduced biological microbes, not consciously, but just as part of warfare. We are now in a global village, and so no nation is insulated from what is happening in any other part of the globe. And so if you hear that something is happening anywhere, you cannot be complacent. I mean, it should be a concern to you. It should be a concern to you, and especially as a public health physician, you must be interested. Human beings will basically reap what we sow, and we cannot cheat nature. The more we increase the deforestation, the more we increase global warming, the more we do things to change the environment, obviously there will be a consequence, and that appears to be something that we cannot hide from. The other lesson is that, interestingly, humanity has great power of resilience. I mean, even though at a high cost, if almost about 200 million people are dying from one disease alone over a short period of time, and yet we are able to rebound, you can see that, well, we have the power of resilience, but by that time, you may be gone, I may be gone. And then there's an interface between animals, environment, microbes, and the like. And so we look at a total one health policy and a planetary health action. And anything that affects an animal, anything that affects the environment, anything that affects humans, it will basically affect each other. And that is a major source of worry. One of the lessons that we have to know is preparedness. You don't wait for the emergence of even a small epidemic before you start acting, because it can overwhelm you before you are aware. And so emergency preparedness and strengthening of general health systems, including capacity, are key before disaster or epidemics strike. And I'll just give you the example of the importation of the about how many ambulances? So almost over 200 additional ambulances before the COVID. Nobody knew about the COVID. Whether it was political, whether it was whatever, was a major benefit during the COVID period, because every district basically had a well-tailored ambulance that became very handy. And so important to strengthen health systems before disaster happens. In fact, in 2015, there was a preparedness assessment in Ghana, how we were able to respond to Ebola had it hit us. And those in red were zero. Coordination was zero at that time. We've learned lessons, all these NTCC, EOC, and other things evolved out of that. Safe and dignified barriers was zero. I mean, we didn't have any system to do that. Capacities at points of entry was basically zero. These temperature monitoring things, screening at the airport and other things all evolved out of this assessment. And logistics, PPEs and other things was actually assessed zero. That was in 2015 by WHO in Ghana. But we've learned quite a lot of lessons. The early detection and response are very, very important. Contact tracing cannot be ignored. And the use of these national ID cards and digital address system, I mean, should be enhanced so that it's easy to trace people and follow them up. And that is basically some of the important things. One of the key lessons is that there's a high risk of nosocomial infection in hospitals and the need to protect health officials. In fact, health workers have actually succumbed, unfortunately, to COVID and other pandemics, and we cannot ignore this. As we keep on pushing for, there's a need for properly constructed, equipped national infectious disease, we will say institute, where capacity building, research, and service are combined. I mean, to be able to address all these things. Then there's a need for multi-sector approach when you want to address any epidemic. It is not an issue about Ministry of Health, Ghana Health Service, or that. In fact, there's a need to bring in the military, the police, and all other agencies in an all government, all of society approach. That basically is the approach. The last slide is the need to invest in vaccine research and development. This is, we cannot emphasize that. I mean, we don't, if we don't get involved, I mean, you'll be at the tail end and you'll be a beggar. But we have the capacity to do that, but it needs investment. Need to prepare in order to deploy any available vaccines. Fortunately for us in Ghana, we are very good at that. And I know that the EPI system is so robust that we are able to deploy because of polio, because of the other vaccines that we have been engaged in. That is quite important. There's a need to establish a network of laboratory facilities for quick diagnosis and confirmation. In fact, at the beginning of COVID, there were only 2 centers in Ghana, and Noguchi and KCCR. Now, gradually, we are building a network of such facilities across board in Kolebu, in almost quite a number of the regional centers. But we need to establish those and strengthen them. The need for emergency funding to deal with epidemics cannot be emphasized. And the last, but not the least, is the risk communication aspect. I mean, whether we like it or not, Africans, Ghanaians, think that they are so blessed by God, so immune to anything that it won't affect them. You only need to take some bitters and you'll be okay. And there's important to address fake news and conspiracy theories. This colleagues, what I was able to gather, and there are quite a number of references that will be available if for anyone who is interested. But thank you so much for the opportunity.
Thank you very much, Dr. Amofah. I think you have dealt the topic very well, and it has been well illustrated from the historical perspective up to date. Ladies and gentlemen, The floor is now open for questions.
And contributions.
Yeah, and contribution.
Okay, just to say that we have a question in the chat, and then we can look at that. And
Okay.
if you want to ask a question, you can please raise your hand. We currently have Kenneth Ofosubakun's hand up. So let's take Kenneth, and then we'll go through the questions in the chat. Okay. Thank you, Kenneth. Please continue.
Thank you very much. Dr. Amofah, that was an excellent, brilliant presentation. Thanks for the research and for illuminating us. I have a question about a very simple subject, but yet a very important one, hand washing. I was in Liberia during the Ebola epidemic when they declared that Ebola was over. And immediately people started kicking out all these hand washing basins and they just bypassed them. Some of them were removed and everything because Ebola was over. Yet, when they were washing their hands, there was no cholera throughout that period. So my question is, with the benefits of hand washing, shouldn't we make it a new culture in this country and insist that COVID or no COVID, from now on, we're going to institute these measures and maintain it as our way of life? Thank you.
Good. I think I can take two more.
Yeah.
Okay, Victor Bampo, please.
Thank you very much, and good evening, colleagues. Dr. Amofah, I think this was a really, really brilliant presentation. I just wanted to make a couple of comments. And first of all, I wanted to say that I think that to a very large extent, as public health physicians, we know what has to be done. And I think the problem is how to push this into policy and practice and get the politicians and the decision makers to see things our way. So I'm hoping you could probably guide us a little bit in how we can get the people who make some of the decisions to see things our way. So I think globally that has started to happen. So for example, the paradigm shift from the traditional global health security where it's just the West trying to prevent disease that is coming from the South. And now the paradigm is shifting to a global health solidarity approach. And I think you also mentioned the fact that, nobody is safe until everybody is safe. But in Ghana, I think we still have challenges. For example, on the vaccines, when we tried to do the clinical trials in 2015 and Ebola, and the pushback, and subsequently the kind of falling back that we have had because we have not been at the forefront, and some of those kinds of things. For example, you mentioned ambulance, and this will be my last example. And yes, I'm trying to be a bit facetious here, but the ambulances have to dock in facilities. And when in 2015, 16, we were trying to put up facilities, there was some sort of pushback about not needing facilities. And then we are realizing now that we do need them. So how do we get some of these things into the mindset, into the planning process so that we can benefit from it? Over. Thank you.
Yes, I think that Theodora's hand is up, and I'll take that one, and then I'll respond.
Okay, thank you,
sure.
Dr. Amofah. Thank you, very excellent presentation. I really enjoyed it. My question is that we have clearly seen the benefit of vaccines throughout your slides and throughout the years, as you have indicated. Why can we not start producing vaccines in our own country?
Good. Yes, that is the question, and I will I agree with you. I don't see why we cannot. I think we have the men to do that, but it requires a lot of investment. I mean, the research institutions, the academia have to be definitely brought on board. they have the capacity to do vaccine production. Noguchi and other bodies definitely have the men, if they, but it will have to be a collaborative effort. I think initially we can link up with other colleagues from South or North-South or whatever. I mean, and gradually move in stages. I mean, it needs political commitment to do that, and because the benefits will not be seen immediately, but as a long-term program, I think we all have to push for that. Just as we are pushing for the establishment of the Public Health Institute. In fact, immediately we push for the establishment of the infectious disease hospital. You can see that within a matter of 4 months, 5 months, it has been possible to at least construct something like that in Ghana. We are told that about 3 or so are also in the pipeline. In fact, most of these started also during the Ebola discussion. I mean, because that was the experience. And as far as we are concerned, we need an institute, a public health institute that will combine research, development, laboratory, service, epidemiology, and then capacity building, training. I mean, all embodied, and then so that they become a center of excellence. I mean, to be able to churn out people to move forward. That basically is the long-term approach which I will endorse. Yes, there's a vector. It's nice that you always join us, because I mean, so some of these things we did together at our time, and gradually we've been able to build on this. I mean, we push policy. In fact, some of us are members of the NTCC, National Technical Coordinating Committee of government, where we basically push quite a number of these issues forward. The issue about expanding laboratory support and other things is a collective decision where almost all of us are involved. This vaccine issue, at least the COVAX one, if you remember, at our last one that was given on vaccines and other things, that was a recommendation to that. We actually followed it up. At that time, Ghana had not signed to the COVAX, and now Ghana has been the first beneficiary, at least, of COVAX, even though that is not the best of the options, but at least as of now, that is what we have. It's just to cite that advocacy is actually in progress, and we are able to push for some of these things together. There is not something one person, one agency, one group will be able to do. But even through the World Federation of Public Health Associations, in fact, this fight, the global fight to make vaccines accessible and affordable to developing countries is basically ongoing, and they are all linked to what you mentioned, and they are all part of the global effort. And though both at the global level, at the national level, some of these advocacy activities are ongoing. Yes, Ken, I mean, you couldn't have said it better. Not only the hand washing bit, but even some of the greeting culture terms that are familiar, we are too familiar with. I mean, somebody goes to toilet, I mean, he doesn't wash the hands, I mean, and then you greet about 50 people shaking hands here and there, and there won't be any facility to wash hands. And so yes, I definitely endorse that. People don't like it. I don't see why. People will want to use sanitizers. I mean, instead of ordinary soap and water. I mean, if it's part of our culture, the diarrhea diseases are definitely going down. I mean, the data is there, even in Ghana, including cholera. And I think it's something we should be able to continue moving forward.
Thank you, Dr. Amofah. So I'll take the questions from the chat, and just to add that if you want to make a comment, you can still raise your hand and I'll call you. This from John. He says, looking at the positive impact made by vaccines in the reduction of mortality for measles, will we say that the current COVID-19 vaccine will do the same? If yes, do we have some data to prove this in other countries that have started the vaccination against COVID-19? And then he asks a second question. He says that, what is the limitation in producing vaccines in Ghana? Looking at all the big brains we have in public health and other important areas in health. So that's from John. Theodora also said, what is the current agency involved in exploring vaccine development in Ghana? Currently, do we not produce any of these vaccines for use in the country? Rosemary says it will cost between $30 to $50 million to build a vaccine factory, and about 70 million to test the vaccines. Okay, so are we prepared to invest, or will we continue to say we are the guinea pigs? And Dr. Victor Bampo also comes and says, actually, the COVAX example you give is an excellent example. We spoke about it at the last meeting that has come to fruition. So, Dr. Amofah, can please react to this whilst we wait for Hans to come.
Yes, let me start from there. I mean, this is not either or issue. I mean, most of these things should be happening concurrently. Before you are able to invest in those high funding, the development, especially for vaccines. I mean, you definitely have to collaborate with international research agencies. It just once again, the issue about the conspiracy theories, how to deal with them, and making sure that the local scientists are credible. I mean, there's now so much trust in Food and Drug Authority that it looks as if the people actually accept most of the things they come out with at the African level, or West African region, and even globally. I mean, if you are a specialist, remove yourself from politics, partisan politics. I'm not saying for politics, but just because you see in Ghana, it's just a matter of saying, oh, MPP, NDC, and then almost everything stops. I mean, but that will not help us. And so if somebody realizes that some government has started an initiative which is a good and for the betterment of the country, but it will take a longer time. Still, I mean, we should be able to buy into that, even if there's a change of government. I mean, that basically is the way forward. The challenges of vaccine development, I think have been mentioned. One is capacity, and capacity that don't necessarily mean that we don't have the men, but obviously they need to be supported. I mean, you can't build capacity and end anywhere. I mean, it's a continuous process. The type of equipment, the type of financing to be able to do all the clinical trials, stage by stage, is a very expensive endeavor. And I think when we collaborate, this is where we can collaborate with our European and North American partners. I mean, initially to be able to do those. And so those will be some of the things I will say for now. In terms of COVID, vaccine as at now, I don't think we may be fortunate to have it as efficacious like in terms of preventing disease infection than preventing disease. It looks as if it's going to help us prevent disease rather than prevent infection, at least as at now. I mean, in Israel, almost 94% reduction of cases of COVID, the disease, I mean, has been documented. But in terms of whether the incidence of disease infection itself will go down, it may, and we are hoping that it will. But I think so far that is not proven. What is proven is that the mobility definitely will reduce, and the caseload in hospitals, severity of cases choking our facilities will definitely be prevented. And then if you are lucky, herd immunity will gradually build up, and then it will be to the benefit of everybody. I'm sure some of the other vaccines may be probably a little more better at preventing infection than others, but so far that has not come out very clearly. Over.
Thank you very much, Dr. Amofah. I will take Michael Bainu. Michael, please, you can unmute and speak. Okay, then let's take Victor Bampo, and then we'll come back to Michael.
Thank you, and sorry to hog the conversation. Doc, I just wanted to just make a small comment about the vaccines and push a little bit, because I think that the biggest thing that we need, we definitely have the people. So I can, even for now, if you think about CEPI, which is the Coalition for Epidemic Preparedness and Innovation, which is leading on these vaccines. We have a Ghanaian there who's the head of innovations. Well, half Ghanaian, Dr. Da Costa. We have Linda Arthur, who is the vaccine lead for J&J and all that. Yeah. I think there's something missing, which is that I don't know what to call it. That push from the decision makers to push to put us in the mood to do this and commit the resources. That's why I keep saying that we know what has to be done, but I think we should spend some time thinking about how we can interest the people who make the decisions to get into those kinds of decisions, to make those kinds of decisions. Over.
Yeah. Yeah, I think I agree with you. The only problem is the competing priorities. Once again, I mean, somebody will be thinking about this. Bobo who today refuse them at the back, and those type of road construction to my account, and the same resources. But I mean, we don't have an option. I mean, we have to begin the investment, and the investment that is now. And I agree with you, Victor.
Michael Baini, please, are you ready? Okay, so let's say Kenneth Elfosu.
Yeah, Kenneth.
Thank you very much. I want to make 3 quick comments and observations. One, on the development of vaccines in Ghana. Yes, the important thing is that we must make a decision, we're going to do that. And I think the First Republic had made that decision some years back, during the First Republic, that we're going to start producing vaccines. But the approach was slightly different. For instance, when GHOC was established, it was West Africa oriented. It was going to provide medicines for the West African sub-region. So why can't we start thinking regionally or continentally, where if we come together as a continent, we can set up one state-of-the-art vaccine production facility? That's something to think about. The second issue is to do with your comments on politics. Public health, policy, and politics are bedfellows. So if we're going to practice public health in its true sense, we cannot run away from politics. because the politicians make certain decisions. And public health, we are driven by policies. Policies is what drives us to do what we want to do. So we can't run away from politics. Party politics has caused a lot of damage in this country. But as professionals, we should be able to take a step back and say, look, whichever administration is in office, whether I voted for that administration or not, whether I like them or not, that is a legitimate administration, and we've got to work with them. And so long as we develop an independent mind, independent thinking that this is what is good for the country, we push it. But we don't say that it's this party, I don't like that party, so I withhold my contribution. That would be rather unfortunate for this country. And my third and final comment is that I'm glad the Public Health Association is back on its feet with such seminars. Years ago in the 1970s, when I used to work in Epidemic, when I was coming to Accra, there was this series called it was from the American College of Surgeons or something of that nature. And it was about how I do it. So the guy would say, look, burial swan, this is the standard way, but this is how I do it. And these are my reasons for doing it. Hemorrhoidectomies, this is the standard way, but this is how, and people shared their practical experiences. Can we, as the Public Health Association, start something and build on what we've just started and say that, look, Ken Sego will say, this is how I manage, this region, that hospital, that institution. This person will say, in my clinic, in my public health practice, this is how I handle this, this is how, so that the new generation would also learn from how we did things. I'm saying this because I have in front of me here the September 2020 edition of the Postgraduate Medical Journal of Ghana. Those of you who haven't seen it, go and take a look at it. Under commentary, there is the public health physician. It says public health physician, preventive medicine specialist, perpetually confined to management and administration. And I beg to differ with some of the issues, basically trying to say that the public physician, all he does is administration and management, which I strongly beg to differ. But not until we start sharing experiences and looking at some of these things, we may be shooting ourselves in the foot and not giving the new generation of public health physicians, something to learn and to build upon. Thank you very much.
Thank you so much, Ken. I mean, what you experience, and that's why we need the expertise of everybody, basically, so that, in fact, this year we actually plan that the entire health system blocks will form major parts of the scientific session, so that each month there will be one particular block, whether on leadership, whether on service, whether on human resource, whether on whatever, information, education and communication, that type of thing. And we will definitely be falling on some of you, I mean, to address aspects of what we are trying to achieve. Yes, I mean, public health is politics, but unfortunately, it's not partisan politics, and I will still emphasize on that. I mean, in Ghana, if you want to stop anything happening, you just identify yourself and say that this is NDC, this is MPP. I mean, then it stops, irrespective of the rationality of what you are saying. I mean, people become so fixated on their position. That was what I was actually driving at. But yes, I mean, if we want to influence life, then it's politics. I mean, so there's no way you'll be able to. I always credit myself and say that I've been in the ministry. I've worked with every government from Rollins through everybody at the highest level, and I'm able to work with anybody at any time. And I'm sure people may not even know my affiliations and other things, but I don't look at the partisan aspect, but what can be my contribution to life, and that is basically the essence of what we meant. Okay, can we have more or additional comments, and then we see?
And there's a last question in the chat. I'll read it and then Dr. Agongo can, you respond and Dr. Agongo can give the closing remarks.
Okay.
It says that we can be contract manufacturers for West Africa, but producing a sterile environment is new technology for us. How do we make that leap? And I'm sure it's still in relation to the vaccine production.
Yeah, that's true. There has to be a collaborative effort, like Ken said, Kenneth said, at least from the West African group. And you see that is what the Food and Drug Authority now they are doing. There is a linkage at the West African level and the AU level, where the common the authorities are working together, and so that's why they are able to fast track quite a number of things. So if Nigeria is working on a particular aspect and their Food and Drug Authority has done this, you may need just access to the information, the documentation, and then you share that type of information rather than you alone starting afresh. Then that will take a long time. And people are wondering why the vaccines have been approved so quickly. I mean, yes, it's partly because in the past that those type of technology was not available. You don't have to wait for 5 years in order to develop a vaccine. I mean, when the blueprints and other things are there. And so once you are part of the safety and the efficacy aspects, you don't need to do it yourself, as long as you go through the modalities that are already established. And so there's a need to collaborate with other countries, especially West Africa and Africa region. Michael, your hand is up. We try calling you there. Unmute yourself. Okay.
Dr. Amofah, good evening.
Fine evening, sir.
Dr. Amofah, please, I thank you so much for this particular delivery. I enjoyed it so much. Please, I wanted to ask about you mentioned a particular trend in diarrheal diseases because of this hand washing that was instituted because of the protocols that was existing because of coronavirus. Because of that, there has been a decrease in the diarrheal infections. Please, can we get that particular article or that particular document so that I can also start reading about
it? Those are actually the routine data collection that the entire Ghana Health Service captures. I mean, through the DIMS.
Okay.
Yes, and I think they've done quite a lot of those the disaggregation, trying to find out the effects. At least initially they were looking at cholera in particular, but that one definitely there is evidence. In terms of general diarrhea diseases, I can say in terms of the reporting pattern, yeah, there's also some aspect. We've taken cognizance of the decrease in hospital attendance and other things, but those things have been factored into the equation. But I'm sure there are some studies that I'm not aware of. Ken, are you responding to that, or is it another one?
Yes, I'm responding to that. Basically,
Okay.
I want to refer him to the Ghana Weekly Epidemiological Report, GWER. If you go to the website, every week we publish the notifiable diseases. And you can look at what is happening to diarrhea diseases there.
Okay.
Please take it again. Please take it again.
The Ghana Weekly Epidemiological Report. If you are not on a subscription list, please put your name on there. Every week we publish all notifiable diseases. So you can go in there and see the trend. You can compare the year before COVID and then the year after COVID and the impact of hand washing on the diarrhea diseases. I believe that was your question.
Yeah.
Yes, it is. Yes, it is.
Right. So go to GhanaHealthService.com/
please. Okay.
I said Ghana Health
Ghana
Service
Health Service dot
.org/GWER.
Please, can it be written in the chat box for us so that I can?
Yes, I will.
Can
Yes.
look at it. Everybody can.
Okay.
Right. Okay.
Okay. Please, you're also saying something about subscription.
Yeah.
I didn't get you.
Well, actually, okay. I don't know whether just a moment. Yeah, my mic is open. We've developed an app called the GWER app that if you download and install on your smartphone, anytime there's an issue, you'll be notified that there's an issue, there's a new issue of the GWER, you can log on and you can even read it offline. So I encourage all those who are not up to date with this, and I'll probably put up another post on one of the forums and also on the Google group for physicians, and anybody who would want to do that, we're happy to introduce you. But yes, we did a project, we've developed a GWER app, and that app would give you notification of what is happening, new additions, new interesting features, and so on, so that it will prompt you to go online and read the whole issue.
Perfect. Please, I know I'm asking lots of questions, but please, can we get your emails or something, your contact, so that we can chat?
No problem. I'll put it up there.
Okay.
Yes.
Thank you.
Okay.
I'm grateful.
Okay, then, James, you can, Dr. Gongo, can you take over now?
Okay, thank you.
Thank you very much. Dr. Amofah, please, do you have any
I'm going to make it
final words before Dr. Gongo comes in?
No, I think that is basically just to thank you or I've already said that this year we are looking at the health systems components, and that will influence the type of topics we'll be selecting, because we want to delve into each of the blocks and how they impact on public health. And we would definitely be relying on quite a number of people, both in country and outside, I mean, to look at the different aspects of that. And in the presentations, then they will be able to bring on board some of the key issues that are peculiar to that particular component. And so I would definitely want to encourage all of you to be part of us, be part of the larger group. Public health belongs to everybody, and so you are all invited. Thank you so much.
Okay, thank you, Dr. Amofah, for your brilliant presentation. In my closing remarks, I must state that he has given an extensive profile of the historical development of epidemics globally and zoomed on the Ghana context, the impact, and then the lessons we could learn to move forward. And this could be summed in one statement, that epidemics and pandemics are profound crises that can destabilize the very foundation of society or nations, especially in the health system, the economic, social, and political systems. And that these crises are for us, every nation, society, to take lessons from them and recover and strengthen itself for future battles of such nature. Those who refuse to learn those lessons have their own problem to face in the future. The American Journal, the American Public Health Association Journal published recently a series of articles on this similar topic, pandemic the historical pandemics and the historical perspectives. And in fact, they have highlighted some of the critical issues that pandemics have helped other countries to develop their systems and others have not. For instance, there was an article that indicated the 1911 plague epidemic in China, when that country was then labeled the sick man of the Far East because of the country's challenges at the time. Poor government, there was opium intoxication, and weak systems. And that the Chinese specialists did not see it as an offense, but they worked on it. And that actually brought out how China has emerged strong in 2020 with the COVID-19 pandemic. In similar vein, another article illustrated that America woefully failed in the COVID-19 pandemic. And this article indicated that America has become the sick man of the West. Critically, this is the point that as a nation, the points outlined mean that we should be ready to take lessons from this pandemic and build our system stronger, as the presenter has presented. I think the issue of the Public Health Institute is very relevant, but also equally important and more embracing is review of the Public Health Act. I have heard some news that an attempt was made to review it, but just to look at some few elements of it. But I think this is the right time to comprehensively review it so that any institutions needed to be established must be established by law and captured in it. And the funding mechanism would also be captured so that we would at least be assured of the establishment of a very strong public health system that can meet the challenges of the future. Second comment is actually in relation to the article that Dr. But in the college, and I think yes, the article has a lot of issues with it, but I looked at the positive element of it because it actually wants us to look at public health practice among public health physicians in the country and the job avenues available for them. And it is very important for us to do this because if not, most public health physicians, specialists think that when they finish, they should go to occupy the administrative positions. Meanwhile, the system has not actually created public health specialist positions, practice positions in the various institutions. And I think I was trying to find opportunity to talk to the faculty board to see how it will be brought, this topic will be brought to the fellows table to discuss extensively, because we can't be training our specialists and they are finding it difficult to find appropriate places to practice their skills and competencies. Ladies and gentlemen, I think we have learned a lot from this. Let's spread the message. Let's make sure that where we have the leverage, the policy elements are very key. Let's see how best we can move public health practice forward. Thank you very much.
Thank you very much.
Yeah, thank you for all your support.
Thank you. So this will be the end of engagement this evening. For those of us on our WhatsApp chat, we will give details for our next scientific lecture. And please watch out for other programs for the year, which will be advertised on the platform. Thank you so much. For those who are not members of that session, you can please get in touch with us, and we'll send you the link to apply and then possibly join the association as a member. Thank you very much for coming. Thank you, Dr. Amofah, and have a good night, everyone. Thank you very much.
Thank you.
Thank you all. Good.